top part. So she had this very unusual left middle ear carcinoid tumor, and was treated with surgery and radiation in November of 1998. So a long time before I ever got to meet her. Unfortunately, as a result of that treatment, she was left with a terrible speech disturbance and a really bad kind of disfiguring facial nerve palsy. But she survived it and actually has done remarkably well. So now, just a couple of months ago, she comes back for routine follow-up and says to me, you know, I have to tell you that my speech is worse than it's been. Now, I have to tell you, I couldn't tell, because her speech was bad the very first time I ever met her. She also said that her balance is a little bit worse. I couldn't get much more out of it. And she also said that her facial muscles on that side were weaker, and that the indent on her cheek, which had been there from the initial injury, was deeper. And I can tell you, I couldn't tell that either. Her daughter couldn't tell any of this. But the patient, who's extraordinarily reliable and lives alone and cares for herself, was adamant. So what do? I ask for trouble, right? Because what else would I do? Okay, so this is just a color flow image, kind of with that focal little, I can't do a point, but you can see the color flow disturbance right in that little spot there. And that's her velocity showing, so I think you'll give me that that's the real deal, right?
So before you go down that pathway,
yep.
The differential from that presentation, which could have had a stroke,
yeah.
Did her hearing go down too, or just...
Her hearing's never been good since all of this.
So when you look at the pathway of the facial nerve and things like that, you can be close to the acoustic nerve, and that can give you balance,
absolutely,
facial nerve problems, and decreased hearing. So I know that
recurrent tumor in her bed.
Right. Acoustic neuromas, if you treat them with radiation therapy, when they come back as cancer.
Right.
So those are the kind of things that I'd be looking at, right?
Me too. And remember, it wasn't an acoustic neuroma, it was this weird carcinoid tumor.
Right.
And in fact, when you go back and read her primary ENT doc's notes, she's never had a completely normal axial imaging study post-op and even to date. She's had a little ring enhancement that he keeps writing, I don't know what this is, but I want to watch it. Maybe this is going to be recurrence, okay?
So Mike, a quick thing about that picture. So the radiation therapy was on the same side,
yep.
I suppose, right?
Same side.
So can you enlarge that picture that you just showed? So there's some atherosclerosis, but there is quite homogeneous stuff in there too.
Oh yeah.
So how long before before this duplex was the radiation?
So 1998.
Long time.
Long time ago. So, and this is just to show you her dampened distal waveform to suggest that that's, if you didn't believe it before,
right,
believe it now. So of course I did exactly what you said. I called her ENT guy and I said, look, this can't be her carotid. I can't tell that these symptoms are really new. You got to tell me that you can explain this. And so he saw her right away, re-imaged her, said, nothing new. Don't blame it on me. It's not her ear.
Ring enhancement, I still don't know what it is. I'll keep my eyes on it.
And just to let you know, her right internal carotid's wide open, completely normal.
Vertebrals are
fine. So now what would you do? So you got this 87-year-old woman who's totally reliable and tells you she does not feel right, things are worse. You got this critical internal carotid on the side that she got radiation and surgery, and her ENT guy says this is all on you.
I mean, realistically, I'd call a neurologist.
Okay, perfect. Perfect. So I called a neurologist and he said, you need better imaging than that duplex. I don't buy it. So get me something else. So this is an MRA. And most of you who know me know that I have not really shown many MRAs because I've never been a big believer, but we've got this guy in our place now who's an amazing MR guy. And I think you'll see here that in this critical lesion, I mean, it's a pretty beautiful MR angiogram. Okay? So there's that. Now what?
So,
go to a neurologist, right? So I took her, I sent her to a neurologist. It was a stroke neurologist. And I said, you got to tell me, is this symptomatic or is it not?
Right.
Now, obviously from our discussion with Sean, it's critically important for everything we do, right? Because if she's asymptomatic and, you know, her high-risk situation would be anatomic high risk, right?
Right.
Radiation would be the mechanism, theoretically. And she had a leathery neck and all that stuff. You know, how would we get her paid for?
Right. And you know, with her facial muscle weakness, if her external is, you know, you didn't show it, if it's narrowed her out, you know, some of her facial muscle atrophy could be because if she's really lost her supply to a partially denervated facial muscle system, it might atrophy some more. And that might explain some of it, but not the speech, unless it was a muscular-related speech thing. But you know, you still can't put it all together. It's but clearly it's a tightly...
The external looks like it's got a little disease, but this
It
came
does,
on
yeah.
sort of
rather,
not acutely, but it wasn't like a chronic withering.
Right.
She's not complaining of jaw claudication
No.
and other things might lead
No.
to...
No. Okay, so I sent her to the neurologist. And the neurologist said, I don't know.
Wait, they probably, but they got 3 or 4 more tests before they said that, right? There was
No
a
doubt.
TCD.
Oh, yeah.
Like, let's be fair. There were
Yeah.
3 or 4 more tests
doubt.
before they said they didn't know.
No doubt.
Yeah.
So I talked to my chief of vascular surgery, who laughed at me and said, don't even send her to me. I don't want anything to do with her. And I sent her to Kenny. And Kenny said, this is absolutely a carotid stent case, but I don't know how you're going to get this paid for. It's not my problem. You got to figure that out. I couldn't put her in Crest 2. I had a note from a neurologist saying not convinced that this is symptomatic. I mean, this is a bind, right? So now what? I couldn't really do that. Right? I couldn't just leave her on medical therapy. So you guys are being quiet. So basically you're telling me you don't know what you would do.
I know what we would do.
What would you do?
We would fix it, and we don't care about the Medicare coverage.
Yeah.
The hospital will take that.
So that's exactly what
Yeah.
I mean, the bottom line was Kenny wrote, and I wish he was here because it was a hilarious discussion. But he told me that he had never met her before, right? So he never saw her baseline. And he said, oh, I totally believe her. She's having TIAs right in front of you. We got to do something about this right away. He did. And he wrote it in his note. But we didn't actually care. I said, I don't actually care. So that's her injury. That's pretty impressive, right?
Yeah, it's impressive.
Yeah. And, great result. Very uneventful procedure.
And if you go back one, the things that push you a little bit farther, which I didn't see on the MR, was this deep ulcer.
Yeah, you didn't see it.
You know she's had probably a recent plaque rupture, and it's one of those things where that's a higher risk stenosis from our standpoint. That's not nice and smooth. And
Well, you bring up a good point, Gary, with your fancy Dan MR guy. Did you go back and say,
what did the wall look like?
Yeah.
What did
I did.
the wall look like?
What could he say? Sorry, I didn't see it.
fair enough?
so, are you guys? Do you think a CTA would have done better? Maybe.
I think
I thought
probably would have
it's
seen
like
that,
They usually
yeah.
call the ulcers the MRs.
I mean, that's a big ulcer.
It doesn't look super calcified, so when it's not calcified, I think CTA does pretty well. When it's calcified, though, it
Right.
also
Then you won't see it.
But this
Yeah.
is not calcified, so I bet you would have seen it on the CTA. I guess the question is, Gary and Martin and Michael for would you use proximal protection for this, distal protection? Would you do the Chris Metzger proximal and distal protection? This is a symptomatic person. This is a
We certainly use proximal protection. We use proximal protection. I try to do it on everybody. I mean, I'm just a firm believer in it. But especially in the symptomatics, I push the envelope. I don't do double protection. We are pretty unaggressive about post dilation,
you know, knock on wood, because you're going home to do a case tomorrow, you know. Our even TIAs are down to almost zero anymore. It's just, we just don't see that stuff anymore. And, you know, that, I think that's directly related to being much more conservative on balloon dilation, using a lot more proximal protection, you know, those kind of things. The other thing on this one would be is, you know, you would like to use a closed stent. Do you go around that bend? Don't go around that bend. There's a lot of technical features of here that are controversial. Do you use closed cell, open cell? I mean, there's a lot of different things that we start to manage at that point.
So take us through. We got a little time. What would you have used?
So
and why?
Right. I would have used a closed cell. I would not have gone around the bend. I think it seals these ulcers a little bit better.